start and get everything up and running. All right. Good afternoon, everyone. Today's December the 3rd, and we're going to get started on our Georgia Perinatal Quality Collaborative maternal webinar. Title for today is Hypertension in Pregnancy, the Short and Long-Term Implications for Women. Just a couple of maternal updates. Our next GAP QC maternal webinar is scheduled for Tuesday, January the 7th at 2 p.m. Dr. Catherine Berkler will be our guest speaker. The topic will be fourth trimester care for high-risk patients and telemedicine to reduce readmissions. Just a data update that we are going to be closing out December at the end of this month. So your next data submission into Simple QI will be the end of January the 31st of 2025. A reminder that we will be going into sustainability with our hypertension in the spring of 2025. We'll be sharing more information as we get closer to that. We plan to do a kind of a sustainability webinar as we get closer to that and do some special things around sustainability with our annual conference in April, which leads us to the next update that our 2025 GAP QC annual conference. Go ahead and mark your calendars. It has been scheduled for Thursday and Friday, April the 24th and 25th. It will be at the Emory Conference Center again this year. We've got a great lineup of speakers, and we'll continue to do, just like we did last year, a couple of different breakout sessions with that. So make your plans to attend. We'll be sending additional information out about that probably mid-January. We are working with Dr. Bird. She has put together a video contest. So this is our part of our GAP QC residency program project where birthing partners, she's wanting to basically use the cardiovascular disease screening and pregnancy in up to 1 year and do a recording. It can be like a TikTok, Instagram reel story where either a provider and a patient are utilizing some of the cardiovascular peach cards or education materials, or it could be, you know, a doula or a social worker or an outreach coordinator, whoever, doing education to a patient. These videos will be used in different social media events. We will announce the winners of these at the annual conference. If you're interested in participating, all of the information here will be sent out after today's webinar. It'll also be on our website if you need to get more information about that. Always feel free to reach out to me if you need more information. If you do decide to participate, your entry should be submitted to Dr. Bird, teresa.bird@wellstar.org. So please share this widely. The more the merrier. We'd love to have several of these that we could share and utilize across the state.
Hey, can I just interject real quick? And the video
Absolutely.
can actually be patient-facing or provider-facing. So it can be educating providers about how to use the screening tools or patients on how to use the peach cards or the heart emergency cards. So either way.
Thank you, Dr. Bird. Wanted to share information about Northside Hospital. About every other year, they do the Heart of the Matter conference. That's coming up February the 28th and March the 1st of 2025. You can use the registration link here on the screen or the QR code to register for that. This is just a promotional card here about our conference. Did forget to say that the theme for this year's conference is the fourth trimester, the forgotten phase. A reminder that we did provide 100 seats a couple of months ago for the Institute for Perinatal Quality Improvement, their birth equity modules. If you did register to utilize one of those 100 seats, we would appreciate if you would complete all 4 of those modules. You do get C&E credit after you've completed all 4 of the modules. But again, if you did register, please do complete those 4 modules. And this can be used as part of your equity training, which is part of our key driver diagram for respectful, equitable, and supportive care. We are currently recruiting for wave 3 of our cardiac conditions and obstetric care. If you or your facility are interested in becoming an active or learning cohort for CCOC, this is the enrollment form. It's available on our website. You can use the QR code here on the screen or feel free to reach out to me. If you have any questions, concerns, worries, anything like that, feel free to reach out to me. I can set up a call with you and your team, answer any questions, any concerns, things like that. But we would love to have your facility as one of our learning or active teams. We currently have 16 active improvement teams working on cardiac conditions. We have 5 or 6 that are under the learning cohort, but would love to add to those numbers. And just some real quick other outside opportunities. AIM is starting back up their data lunch and learns in January. These sessions focus on various data related topics, and they occur every other month. And you can see kind of the lineup through July of 2025 there. Additionally, AIM is partnering with Mama's Voices to do some different trainings over the next year. There is a cohort 4 specifically for hospitals that'll begin in February and run through March. So if your facility thinks that you would want to utilize some people with lived experience and integrate that into your QI work, use the QR code here or the website to get more information on that. AIM has also updated their severe maternal morbidity website. That can be accessed with the code on the screen here. They have quick links. They have more specific information about SMM codes, tables, algorithms, all kinds of amazing information. So encourage you to go to AIM's website. There's a short video on introduction to severe maternal morbidity and all kinds of resources that could help your facility in that work. And of course, we always show the driver diagram, which shows Georgia's goal is to reduce severe morbidity and mortality related to maternal cardiac conditions. Our SMART aim is by February the 6th of 2026, which is known as National Go Red Day, to reduce harm related to existing and pregnancy-related cardiac conditions through the 4th trimester by 20%. Using the 5 R's for the key driver there, and then our interventions are embedded into our different focuses here under those 5 R's. If you ever need this or it needs to be broken down, I do have some resources that can help with that. And I do have some slides that I've got saved that kind of break it down and give you examples of tangible things that you can do in your facility. So if Jennifer or I can ever help or set up any kind of calls to provide technical assistance related to the key driver diagram, please feel free to reach out to us at any time. And now, without further ado, I'd like to introduce Dr. Monica, who is the Associate Professor of Medicine in the Division of Cardiology at the University of Pennsylvania. And I'm going to stop sharing my screen and let her pull up her slide deck. So give us just a second to transition. Just a quick reminder again, if you are not speaking or have any questions, please keep yourself on mute. There should be time at the end of the presentation for questions. You can put your questions into the chat. If something comes up, I am happy to, read those questions out loud and we can answer those as we go along. So I'm going to turn it over to you.
Thank you so much for having me today. As Amy mentioned, my name is Monica Sangvi, and I am a cardiologist at the University of Pennsylvania. And my focus is on women's cardiovascular health and prevention, something that I'm very passionate about. And I'm excited to talk to you about preeclampsia today and cardiovascular risk. Let me just see if I can. Okay, let's see if I can get my slides up. Okay. All right, can you see my slides?
Yes, if you'll go down there to put them in presentation. Perfect, right there.
Perfect. Okay, so the title of my talk, as you mentioned, is Hypertension in Pregnancy, the Short and Long-Term Implications for Women. And I don't have any disclosures. And, I just want to start off by reflecting on, why we're here and the idea that, I'm a cardiologist and my focus is women's cardiovascular health. I know all of the people on this call are very passionate about women's cardiovascular health. And when we think about the life course of a woman, for a long time, pregnancy was basically an island. Women would go to their OB or MFM for their pregnancy care. And then when they came back to their general cardiologist or whoever they sought care from before, there wouldn't be a very good bridge or a very good connection between what happened in pregnancy and what happens after long term. And so I think this disconnect has been a disservice to women for a long time. And I think part of the reason we're all here is to really change this paradigm that has been present for a long time. I have 4 main objectives today. Briefly describe the hemodynamic changes associated with pregnancy, review the pathophysiology and diagnosis of preeclampsia, discuss the management of hypertension in pregnancy, and understand the short and long-term implication on women's cardiovascular health. As we all know, pregnancy is a landmark event in a woman's life, not only often punctuated by the birth of a child, and the growth of their family, but there are a ton of hemodynamic and cardiometabolic changes that happen, which is why we really consider pregnancy as nature's stress test for women. And so, like I mentioned, there are so many changes that occur, and I really briefly like to discuss them in a little bit of detail, but I know most of you are familiar with this, so I'm not going to belabor the point. I think the key point about the hemodynamic changes in normal pregnancy is that there is a significant increase in cardiac output a significant increase in plasma volume and a significant increase in heart rate. But what I want to point out in terms of the hemodynamics in a normal pregnancy is that blood pressure should really drop. There should be a decline in blood pressure that naters in the second trimester and starts to climb back to the normal levels in the third trimester. But we should not be seeing a rise in blood pressure, and that is a pathologic change. In terms of the metabolic changes, sorry. In terms of the metabolic changes in pregnancy, in early pregnancy, we see an increase in the insulin secretion. There's relatively normal glucose tolerance and slightly improved insulin sensitivity. The idea here is these changes favor lipogenesis and fat storage. Whereas later in pregnancy is where we start seeing an increase in hepatic glucose production up to 30%, reduced insulin sensitivity, and deterioration in glucose tolerance. And these changes are really, this insulin resistant state is to ensure adequate glucose for the fetus and prevent hypoglycemia. When we think about cholesterol changes in pregnancy, we know that total cholesterol, LDL, triglycerides, HDL all go up in pregnancy, and triglycerides go up the most. They all return closer to baseline after delivery. Triglycerides return back to normal the fastest, whereas LDL can take some time to come back to normal postpartum. So really, it's affecting every system, pregnancy is. And so we have to use the information that we glean from the pregnancy to understand a woman's future cardiovascular risk. And so that's why I kind of think of pregnancy as a crystal ball into a woman's future cardiovascular risk based on how her body handles the cardiometabolic and hemodynamic changes of pregnancy. And in order to kind of think through this from the way I do, from a cardiologist perspective, I like to think about it from a patient perspective. So let's think about patient MJ. So we're going to discuss two patients. So let's think about patient MJ. So she is a 31-year-old female who, this is her first pregnancy and first delivery. She doesn't really have a significant history of hypertension, and she recently delivered at 34 weeks, so quite preterm, due to preeclampsia requiring delivery due to uncontrolled hypertension. She is very concerned. She has no prior history of hypertension and wants to understand why this happened to her. She wants to know when her blood pressure is going to normalize after her delivery. And she wants to grow her family in the future and is scared about the implications for future pregnancies and her heart health. And so what the next few slides really are going to try to key in on some of these questions that were often asked in the clinic. In order to get us all on the same page, which I think we already are, but just for definition's sake, when we think about hypertensive disorders of pregnancy, we it's the spectrum of disorders, and we really use the 20-week mark to differentiate chronic hypertension versus a hypertensive disorder of pregnancy. And gestational hypertension. So if the blood pressure is elevated before 20 weeks, we're thinking chronic hypertension. Whereas if it's happened after the 20-week mark, we're thinking this is gestational hypertension versus preeclampsia, and more severe preeclampsia with evidence of end organ injury. And then we always think about those patients who have chronic hypertension who develop superimposed preeclampsia during pregnancy, but truly a spectrum of disorders related to hypertension. Each one of them have implications for long-term cardiovascular risk. But for the purpose of this talk, I'm really going to focus on preeclampsia. When we think about why does preeclampsia happen? right now there's this two-stage theory of preeclampsia. The idea that initially in the first stage, there is abnormal placentation due to genetic factors, immunologic factors, and environmental factors that result in inadequate blood flow to the heart. So the trophoblast from the blastocyte is not, these are not going deep enough into the uterus, which prevents adequate spiral artery formation. This then results in improper function of the natural killer cells, which is supposed to promote angiogenesis. So all in all, what we're seeing in early stage preeclampsia is that there is inadequate blood flow to the placenta throughout the pregnancy. There's this chronic placental hyperperfusion or ischemic state of the placenta. And then in the second stage, towards the end of pregnancy, we see the result of this lack of proangiogenesis. And we see anti-angiogenic factors rise, and then resulting in endothelial dysfunction and systemic vascular dysfunction, which is what we see in terms of the end organ injury that we see clinically. Because the placenta is thought to be at the core of this is why we think when we deliver the placenta, the preeclampsia should resolve. And so we've always thought of this as a pregnancy issue. However, what we've learned is that the injury that happens, this endothelial dysfunction and vascular injury, probably lasts a lot longer and has long-term implications for women. So in terms of, this is why we think she developed preeclampsia, probably a combination of her baseline risk, family history, genetics, as well as environmental factors. In terms of when will her blood pressure return back to normal, logically, it would seem that immediately after delivery, the placenta is delivered, that we would see a gradual decline in the blood pressure. But that's not necessarily what we see clinically. What we see is this basically parabolic shape curve in terms of blood pressure trajectories postpartum, where systolic blood pressure actually peaks about 8 days postpartum, and diastolic blood pressure peaks about 10 days postpartum. And there are some differences based on race as well as BMI in terms of how quickly these parameters return back to normal. And so this postpartum period becomes extremely critical, especially the first 10 days postpartum, in terms of stroke risk and the effects of the blood pressure elevation. And so that's why this postpartum time period requires really close monitoring for these women. In terms of normalization of blood pressure, when we think about, a big question that these women have is, when will my blood pressure return back to normal? And what we know is that about 80% will normalize by about 12 weeks postpartum, but 20%, and some studies show even more, don't normalize. And the normalization of blood pressure depends on several factors: race, BMI, underlying presence of chronic hypertension or elevated blood pressure at baseline, the severity of the preeclampsia, as well as whether they're discharged with antihypertensive medications, which is likely a proxy of the severity of the disease. And so after 12 weeks gestation, if blood pressure has not normalized, we often consider the diagnosis of chronic hypertension. And this is obviously very distressing to some women who have never had hypertension their whole life. And now we're telling them that the medications that they're on will likely be lifelong medications. Okay, so let me just, I think most high volume centers now have some type of text-based blood pressure program to monitor women in this postpartum time period. This one was Heart Safe Motherhood was a program developed at the University of Pennsylvania, looking at the time period after delivery, and they found that a lot of women weren't able to come back to their follow-up visits for blood pressure monitoring, which we all understand. I mean, with a new baby, there's so many competing factors that they often were being readmitted because of uncontrolled blood pressure, or and so there was a relatively high readmission rate for these women. And what this text-based program allowed is a drop in that readmission rate and an equalization of some of the racial disparities that we're seeing in terms of the return rate and blood pressure monitoring that we saw postpartum. And so the blood pressure program that we have here is for 10 days. Women are texted a reminder to check their blood pressure, and then there is a system by which elevated blood pressures are managed by a physician. In order to accelerate recovery of blood pressure, this is another trial that was done here at the University of Pennsylvania, looking at the use of furosemide to accelerate the recovery of blood pressure. So women who had postpartum who had any kind of gestational hypertension were given Lasix for 5 days, 20 milligrams of Lasix for 5 days. And what they found is that there was a 60% reduction in persistent hypertension after 7 days. And the days to resolution of hypertension was also decreased. The thought being that because of this increased plasma volume associated with pregnancy, that this helps kind of improve the volume status of these women. We also know from the POP-HT trial from the UK that closer blood pressure monitoring and more aggressive blood pressure control immediately in the postpartum period probably has implications longer term. And so in this study, they looked at, they randomized women to standard care, which was a blood pressure measurement at about 7 to 10 days, 1 week postpartum, as well as 6 to 8 weeks postpartum, compared them to really much more aggressive blood pressure management by a physician, but the blood pressure was self-monitored, kind of similar to these text-based programs where women are checking their own blood pressure. And what they found is that at 9 months, even though most women were already off their blood pressure medications, that those who had the more intensive treatment early on had lower diastolic blood pressures at 9 months. And a subsequent sub-study of this showed that there were actually changes in the cardiac structure, improved cardiac remodeling in those women who had better blood pressure control early on. So I think what we take away from this is that this critical time period in the weeks after delivery, where blood pressure is initially rising and then improving, requires close monitoring and probably may benefit from more aggressive treatment, whether it's through diuretics, whether it's through just blood pressure control. The other thing that I wanted to just mention is that although most of the time we just look at the blood pressure in clinic, we can't forget that actually a large percentage of these women actually go on to develop masked hypertension, which we might not catch in the clinic. And so some type of home blood pressure monitoring, whether that's a formal ambulatory blood pressure monitor, could be beneficial in order to evaluate for masked hypertension, which also has long-term cardiovascular implications. When we think about what does preeclampsia mean in terms of long-term cardiovascular outcomes, it has implications across all cardiovascular events, whether this is arrhythmia, stroke, coronary heart disease, cardiovascular death, valvular disease, but I think the strongest association is really with heart failure. And within heart failure, it's heart failure with preserved ejection fraction. And so we have to have a very high index of suspicion in this population for the future risk of HFpEF in these women. We also know that adverse cardiovascular outcomes are worse in women with recurrent and preterm preeclampsia. And like this woman that we initially mentioned, she delivered at about 34 weeks. So her risk for cardiovascular death and just overall cardiovascular events is much higher than someone who had preeclampsia at term. In addition, when we look at recurrent preeclampsia, the risk is also higher in women with multiple episodes of preeclampsia as opposed to just one. So there is obviously benefit in trying to prevent recurrent preeclampsia. Although this is a small study, I actually use it in clinic in order to help educate women in terms of the risk of recurrent preeclampsia. So this study looked at, it was a retrospective study that looked at the gestational age at birth, that's the left graph, as well as the pregnancy BMI for the second pregnancy. And what they found is gestational age at first birth. So the earlier the pregnancy, the earlier the delivery, the higher the risk of recurrent preeclampsia. In addition, those women with a higher BMI compared to in the second pregnancy had elevated risk of recurrent preeclampsia. And so I always advise women to try to return to their pre-pregnancy weight and to shed that retained weight after delivery before their next pregnancy whenever possible. I think this is a tough conversation to have at such a vulnerable time period in women's life when they're already struggling with so many different things. But when I feel like it's an easier conversation when I use the concept of recurrent preeclampsia as a reason to return to their pre-pregnancy weight rather than just counseling on weight loss. We also know that most of this risk associated with future cardiovascular disease, about 2/3 of it, is mediated through traditional risk factors. And I think this is a good thing in terms of future cardiovascular risk prevention. If 2/3 of the risk associated with hypertensive disorder of pregnancy and heart disease is mediated through traditional risk factors, if we can be aggressive in the postpartum time period about managing these risk factors, we should hopefully be able to bend the curve. And so that's what this next slide really is trying to bring home, that I see a lot of these women in the postpartum time period. Almost all women with severe preeclampsia are referred to our clinic. And so I see several of these women every day in my clinic. And so I think my goal in terms of managing their risk is to try to bend the curve for them. If I can catch cardiovascular risk factors early in their life and educate them early, my hope is that really through primordial and primary prevention, I can help prevent cardiovascular risk in these women. So coming back to patient MJ, in terms of why this happened, we really think that this is a placental ischemia issue and not necessarily her fault, although, but we do know some lifestyle factors and environmental factors could lower her risk in the future. And in terms of normalizing her blood pressure, usually within 3 months, if women are going to normalize their blood pressure, they should. I had one woman who normalized after 1 year, but in general, after 3 to 6 months, if they have normalized their blood pressure, there is a strong chance that they're going to have chronic hypertension. And she wants to grow her family and is scared about her future pregnancy. And I think I always talk to them about the fact that this is not a prohibitive risk, but we need to be proactive about future pregnancies and managing that risk. And then as we discussed, the implications for long-term cardiovascular health and getting regular follow-up for risk factor screening. So let's shift gears to patient JT now. She's a 27-year-old female who's G2P0 at 12 weeks gestation with a history of hypertension at baseline, who comes to discuss hypertension management in pregnancy. And her questions are, what are the implications of hypertension prior to pregnancy? And what should her blood pressure be during pregnancy? And are there blood pressure medications to avoid? I think this really brings up this important point that in general, there is a decline in optimal cardiovascular health across all races and across all age groups in the United States. What we're seeing is that there are increasing rates of diabetes, high blood pressure, obesity. And so when women do not have optimizations of these cardiovascular risk factors, we see an increase in cardiovascular risk as well as pregnancy-related risk. Over time, we've seen in the past decade or two, we've seen an increase in the hypertensive disorders of pregnancy across all age groups. Because I think for a while we thought it was because women were getting older and older women were getting pregnant, but even younger women are having more hypertensive disorders of pregnancy. And so bottom line is the higher number of suboptimal cardiovascular metrics at baseline is associated with adverse outcomes in pregnancy. And so with an increased risk of maternal and fetal outcomes. So whenever I think of any woman coming to my clinic for whatever reason, whether it's palpitations, whatever it is, I really think anytime a young woman enters the healthcare system, it is the time to improve cardiovascular risk and improve maternal cardiovascular health. And so I use any preconception counseling and interconception counseling as a time to discuss risk factors and modify them, because we know that this has implications for maternal and fetal health. This diagram is from the New England Journal of Medicine, which I think is a nice way to depict how we can improve cardiovascular risk and reduce the risk, of preeclampsia in women during gestation. The fact that regular exercise in pregnancy can reduce the risk, initiation of aspirin, as we will discuss a little bit more, as well as the timing of birth. Calcium intake, I do ask women about calcium intake, but the data regarding calcium is really more in third world countries in terms of most people in the United States are getting adequate calcium intake. So it's not as big of an issue that I harp on during pregnancy. As you all are probably aware of, the U.S. Preventive Task Force recommends aspirin in pregnancy. If they have any of the high risk categories, and for the woman we just talked about, the underlying chronic hypertension would put her in the high risk category. And the recommendation would be for aspirin. And then if they don't have a high risk factor for preeclampsia, if they have multiple moderate risk factors, we would initiate aspirin. I think most patients of ours are getting aspirin during pregnancy at this time. And this data from a little bit older now from the New England Journal of Medicine shows that it really helps to reduce the risk of especially preterm preeclampsia in women receiving aspirin. In terms of blood pressure control, the CHAP trial really helped reduce the blood pressure targets for patients with underlying mild chronic hypertension, like our patient. And so trying to maintain a blood pressure of less than 140/90 is what I usually target. I think one of the challenges that always comes up is those women with white coat hypertension and the management of white coat hypertension in pregnancy. We really rely on home blood pressure, calibrated home blood pressure cuffs at that time. But of course, we treat them with aspirin because we know that there's elevated risk. But I find that this group often is a little bit more challenging to manage. In terms of medication recommendations in pregnancy and lactation, as you all are probably aware, our go-to is usually nifedipine and labetalol. We use a lot of amlodipine at our institution as well, with good outcomes. Methyl-dopa we barely ever use for blood pressure just because it's such a mild antihypertensive. And then during lactation, similar meds, but we also consider hydrochlorothiazide for patients with difficult to control blood pressure. So for our patient JT, in terms of questions that she would come to in our coming to the clinic in terms of the implications of hypertension prior to pregnancy, we know that hypertension, and especially uncontrolled hypertension prior to pregnancy, is associated with increased maternal and fetal risk during pregnancy. And so I really, really focus on trying to control blood pressure before women get pregnant. And what should her blood pressure target be? Really focusing on that less than 140/90 throughout the pregnancy. And then we talked about blood pressure medications to avoid. In pregnancy, it's really just ACE and ARBs or any RAS inhibitors. Otherwise, most blood pressure medications we feel comfortable using if needed, but our go-to would be nifedipine, amlodipine, labetalol. So when we think about the timeline of risk associated with preeclampsia, I think of it in 3 time periods when I'm counseling women on risk. First is immediately in pregnancy, preeclampsia associated with multiple fetal and maternal adverse outcomes, including preeclampsia, headaches, abruption, fetal growth restriction during pregnancy. But that critical postpartum time period is really important when we think about preeclampsia, given the risk of stroke if the blood pressure gets to be very severely elevated, as well as heart failure, the risk of peripartum cardiomyopathy. And as we know, preeclampsia is associated with increased risk of peripartum cardiomyopathy, as well as acute kidney injury and severe hypertension. And then, so counseling women immediately postpartum on what to look for, as well as counseling other healthcare providers on how to differentiate pregnancy-related symptoms versus pathologic cardiovascular conditions becomes very important. And then in terms of future cardiovascular risk, I know this is something that's discussed often, that this 4th trimester of pregnancy and beyond is really, really important in terms of evaluating these women for risk factors, treating risk factors, but also I think something that is on top of all of these women's mind is the risk of recurrent preeclampsia and what the implications are for future pregnancies. And, I'd like to end with just really highlighting something that we're all aware of, but, the importance of the fact that of what you all are doing with this collaboration and why these kind of discussions are so important. And the fact that the US stands apart in terms of having the worst maternal death rates ever. And so really, really focusing on the fact that this is not one person's problem. This is a whole health system's problem. And as we know that this maternal death rates have been rising in the US. And so we have our work cut out for us. And as a cardiologist, I am constantly reminding my colleagues that cardiovascular disease is a major cause of death in these women. And if although it feels like it might not be their lane, but I'm constantly trying to convince my colleagues as cardiologists that this is all of our lane. And we have to understand and be able to treat pregnant women through their pregnancy, as well as being able to recognize cardiovascular disease postpartum. You know, it is astounding to me how many women we see postpartum who come to the emergency room and are sent home because even with abnormal EKGs and abnormal troponin levels, just because they seem like they're healthy because they're young. And so it is an education. It is a constant education education process to the emergency room physicians, our colleagues. And I always harp to my fellows that a young woman who's postpartum, who's coming to the ER, if her BNP is elevated or troponin are elevated, do not send her home without calling one of us, because I think these women are often undertreated or dismissed. And I think that is actually a huge disservice. And as you all know, that a significant number of deaths can happen much after delivery, up to a year after delivery. And so we're not out of the woods just immediately at postpartum. And so the fourth trimester care is critical. And so going back to the analogy that I originally brought up in terms of this island, and I think pregnancy has been an island for a long time, but we really need to build bridges connecting it to all other parts of the health system and understand its implication for future health throughout a woman's life course, so we can all do our part in optimizing maternal health. And so the take-home points, pregnancy is associated with significant hemodynamic and cardiometabolic changes and is a stress test for women. Consider each visit with a young woman as an opportunity for risk assessment and risk factor modification, which can improve maternal health and fetal health. We talked about hypertension management in pregnancy, requiring special considerations and goals. And then women with hypertensive disorders of pregnancy are at risk for adverse pregnancy outcomes during pregnancy, development of hypertension postpartum, and cardiovascular risk long-term. And pregnancy can no longer be an island on its own. Thank you so much. Happy to take questions.
Thank you so very much. Wonderful presentation. If there are any questions, feel free to type those into the chat or feel free to come off mute.
Dr. Monica?
Yes.
Hi. My question is, I know that you showed the CHAP study with the 140/90 being what you're trying to keep
Yes.
women under, but what if
Yeah.
a mom starts out pregnancy and she's at 90/60 as her baseline? What becomes her alarm system for reaching out to you for blood pressure elevation?
Yeah, that's a good question. And I think that I think what you're getting to is, what if we have a different baseline to start with? And so how do we um, counsel and manage those patients? So I think, I think one key thing is that the CHAP trial really looked at just patients with underlying chronic hypertension. And so if 90/60 is her baseline blood pressure without off medications, then, unfortunately, we don't have a lot of good data on what the blood pressure goals are for those women. And so 140/90 would be a very good target in terms of start initiating medications. unless the patient is reporting symptoms before. So if she's having severe headaches prior to that, I might assess labs to look for proteinuria or other evidence of end organ injury to suggest that there is more significant injury because of that hypertension. But otherwise, regardless of the baseline blood pressure, we use the same targets at this time. And if she has chronic hypertension and her blood pressure meds are treating her, keeping her blood pressure that low, I would take her off the blood pressure medications prior to pregnancy. I hope that answers your question.
Yes, ma'am, it does. And thank you so much for
Okay.
this. It was great.
Of course.
There's a question in the chat. It says, what are your thoughts on recommending low-dose aspirin for all pregnant women of color with or without risk factors?
You know, that's a good question. And I think there was actually a New England Journal of Medicine article. It was either an editorial or a statement where there was a strong opinion not to do that. I don't know that I 100% agree. I think we have to treat the risk, and I understand that we can't just treat everyone based on their color of the skin or based on racial profiles, and that's not what we're trying to do. But I think we know that women of color are at much higher risk for preeclampsia, and the risk of aspirin is so low that the benefits probably outweigh the risk. But I think there is a little bit of controversy in this space. So, but oftentimes, you know, with current risk factors, there's even if there's no race isn't a factor. There's so many other, you know, whether they're nulliparous or their BMI is a certain threshold that we're able to start aspirin, even if we're not looking at race. So we don't practice like that right now, but I do see, you know, the way I do see how that increased risk in this population could justify just treating everyone.
Thank you. Any other questions for Dr. Singhavi? Wonderful. Thank you so much.
I think there
Go
was
ahead.
one other question about aspirin.
Oh, yeah, I see it now. I'm sorry.
No, that's okay. And so, you know, I think it's the why aspirin works. I'm not 100% sure. I think of it as it probably affects the angiogenic versus anti-angiogenic ratio of factors, but also helps. You know, when we look at the placenta of women with preeclampsia, it looks very similar to an atherogenic profile that we see in cardiovascular disease. And so I think there is benefit of aspirin from platelet aggregation and also other factors, but I also believe it probably helps with vasodilation. And then in terms of when in pregnancy we stop it, usually at 37 weeks, we discontinued the aspirin.
Perfect. Any other last questions? Feel free to come off mute or type into the chat. Dr. Singhavi, I'm not seeing anything. Thank you so very much for a wonderful presentation. And thank you for taking time out of your busy schedule to support the work that we're doing here in Georgia. And for all of you out there that have joined us today, thank you for taking time out of your busy schedules. If you have any follow-up questions, feel free to reach out. I'll send a follow-up email with the resources from today's webinar, the slides and other things, and a reminder that the webinar will be available on our website and on DPH's YouTube channel in the next week or so for sharing or reviewing. Please make plans to join us in January as we continue our GAP-QC maternal webinars, and have a wonderful rest of your day.
Thank you so much for having me.
Thank you
Appreciate it.
so much.
Take care. Bye.
Thank you.
Bye-bye.